Welcome to May I Interrupt, an eye care roundtable discussion show sponsored by OCULUS. Each show we explore questions in the world of eye care and other topics with leading experts in the industry. We do this in an irreverent, yet we hope funny type of manner. I'm Craig Norman, and I'm joined by my pal, the most noteworthy, sought-after lecturer, and possibly the greatest contact lens designer since the invention of PMMA, Dr. Jason Jedlicka from Indiana University School of Optometry. Hi, Jason. How you doing, man?
Hi, Craig. Well, I feel great now with that ego-boosting intro, but unfortunately, I don't keep score, so all that was for nothing, unfortunately.
Yeah.
Other than I appreciate you, Craig, and may I just add that you're looking great today?
Looking great. Yeah. Okay, I'll explain what that bell is in just a minute, as Jason is sucking up to the moderator for today.
I have to start early. I need all the help I can get.
Jason, we have two great guests today. Mm-hmm. Clark Chang, first of all, is Director of Specialty Lenses in the Cornea Department at Wills Eye. He's the host of the popular podcast show Chang Reaction, and he's been named as the top doctor of 2020 by the National Keratoconus Foundation. Congratulations, Clark. That's pretty cool.
Thank you. Thank you,
Over
Greg.
a decade of research experiences in corneal crosslinking and other advanced treatments, Clark has published extensively on keratoconus management, other innovative contact lens technologies, and modern refractive surgeries. And he is ubiquitous. He's kind of everywhere you look, whether it's online or at meetings or whatever. Clark pops up all the time.
Hey, Craig, can I just say your vocabulary never fails to amaze me.
Ubiquitous?
Yes.
I practiced it all day.
I can tell. You had it down. You pronounced it right.
Thank you. Thank you, Jason.
Yeah.
Really.
That's two dings now. May I just say, Craig, you're the most handsome person in the world.
Yeah. I learned another word today that's almost like ubiquitous. It's obnoxious.
Well, you pronounced that one right too. That's pretty good.
Yeah. I'm not saying a word. I've heard it enough and I'm able to repeat it.
Got it.
Also, we have Andy Morgenstern with us. Andy's the founder of OCULUS, a healthcare and management company. He's a clinician with special interest and expertise in anterior segment ocular disease, refractive surgery, corneal cataract disease detection, which we're going to be talking about a lot today, diagnosis and its treatment. He's a graduate of Boston University, Nova Southeastern University College of Optometry, and he completed his training at the esteemed Bascom-Palmer Eye Institute at the University of Miami School of Medicine. Andy, thanks so much for you two spending your time with us.
Thank you so much. And just to beat Clark, I think you look outstanding today, and I can actually smell you from here, and you smell great.
Wow. I can't give you any bonus points there, Andy.
Jason, I just have to say you don't stand a chance in health.
I know. I feel it already.
Okay, so let me explain. So our format is this. We're going to ask three different sets of questions today. We're going to ask them of all three of you, and the topic today is primarily keratoconus. We are going to give you 2 to 3 minutes for each of these sections or so, give or take. If you say something that is really astute or you suck up to the moderator, you'll get a ring. We count up the number of rings a couple of different times throughout the episode today. And then at the end, we declare a winner. And the winner receives absolutely nothing. But you might like it. Other than that, there are no rules except for the name of the show, and that is May I Interrupt? And at any time, you can jump in and interrupt. We actually gladly like that, especially if you can add something that is either more meaningful than the present speaker, or if you want to take a shot at him, that would be fine also.
Pretty much anytime I'm speaking, you can interrupt and be more meaningful. So,
what we muted him, didn't we? Okay, so let's get started. Here's what we're going to do. Jason, as always, we start with you so you get a chance to get on the board before anybody else.
Right.
All of you guys are considered experts in keratoconus. If you could share with us, how has managing keratoconus in the practice changed in the last 5 years?
Wow, the last 5 years, huh?
May I interrupt? Oh, I'm
Sure,
sorry.
go
That
right
was not-
ahead.
I'm sorry. That was not for me. I'm
Oh,
sorry,
okay.
Jason.
Well, I mean, I think that the management in the last 5 years, I don't know that it's changed that much for me. I feel like, we're doing a better job of using our instrumentation to um, look for subtle signs of progression because um, we're more into treating and doing the cross-linking, at the most appropriate time. And I think probably we're just more careful about recommending it and talking about it with patients. I know, for example, I've got a patient that was referred in that's coming in this evening, and we already have a diagnosis, but we're going to spend a lot of time tonight just talking about the long-term picture for this patient, what can be done now and in the future, and then we'll talk about vision correction options and not have anything, necessarily decided, but be open-minded about what works for the individual patient to give them the best lifetime of vision we can ahead of them.
Okay. So interesting. But to answer the question,
Oh, did I dodge it?
May I interrupt?
Andy, go right ahead.
Yeah, sure. So first of all, I just want to say thanks for having us on. Clark and I have been interrupting each other for the better part of the last decade. So I think this is going to become old hat. And all of us have known each other for years now. I will say I disagree with Jason a little bit. When his original statement was that he doesn't know how much it's changed over the last 5 years. And I find that ironic coming from someone who designed such a great lens because, and not to suck up to moderator number 2, but, the device that he's worked on, as the iterations have come out, as the information has come out, it's actually become easier and easier to fit these patients properly with these great design, well-designed lens, Jason, and the work that he's done being one of them. Secondarily, I think if you look at the, Andy Morgenstern, the individual, and then, the greater population of doctors of optometry and ophthalmologists out there, I think it's become a much easier diagnosis to talk to patients about because we've learned so much more in population studies and how much this affects the population out there, where we're actually much more likely to look for the disease of keratoconus and corneal ectasias earlier in the eye exam and prioritize it higher in what we're doing. That being said, I think this is an evolutionary game that we're playing with corneal ectasias and keratoconus. We're all going to get better. We're all going to understand more. We're going to get better when we get better contact lenses and designs, and also devices out there. Bing bong. All right, I'm getting the Gong Show hook.
I'm giving you my own dings, so.
So I think I'm a little too late to interrupt, but I do have something to add. I want to. Oh, am I getting a bonus ding? Yay for me. Okay, so I actually think that there's even more change than what both of them have said, and that is I think we turned keratoconus from a management of despair to actually giving patient a lot of hope. And that is not just coming from cross-linking, stabilizing their condition that we never knew that we could do, and also so many different gray lens designs, such as the one that Jason designs, has given patient a lot of quality of the visual quality and the quality of their life back. So I think now it's about giving them hope as well as customizing treatments that fits their lifestyle, that fits their different stage of their condition wherever they may be at. So it's very different from, say, 5 years ago.
In addition to treatment, I'm sorry to interrupt. May I interrupt?
You may go.
Yeah. To add on to Clark, to have that discussion earlier and earlier is happening over the last 5 years. We've started having those discussions on optimization of vision and optimization of treatment, as Clark was alluding to earlier and earlier in the game. So it really provides increased quality of life for these patients.
Yeah, and I guess I would just go back and say that a lot of the approach in managing keratoconus for me probably took place just a little more than 5 years ago. If you said, how does it change compared to 10 years ago? I'd say it's radically different. But the jumping on with cross-linking and Skleros, I guess for me has been more in the 5 to 10 year range. But one thing I do think is interesting as we talk about vision correction is I think I have more patients than ever with keratoconus wearing glasses and soft disposable toric lenses because their conditions are either A, caught earlier and stabilized, or we've stabilized them at a point where their vision hasn't gone so far downhill that they're unmanageable with more traditional means of correction, which is awesome.
Okay, and any of you fellows tell me how many cross-linking procedures are done annually in the U.S.?
Oh,
I can tell you that I don't think we're going to have a spot-on answer for you right now without talking and looking at coding information that's gone through. And that's even a little bit sketchy because the billing and coding for it hasn't been as long-term as we wanted to. And there's also off-label devices out there that are not being tracked at all within the United States. Still great devices, but they're being used in an off-label procedure. There's no way we can keep track of it. I could tell you that it is readily available throughout the United States. And I guess if we're limiting this to discussion to the United States, readily available in the United States. It's readily available within the U.S. military. And so other than cost being a factor for some folks that don't have insurance coverages, I think the accessibility to it is out there. It wouldn't shock me if we were in the high thousands right now.
Thank you, Andy. So let me just build on that for a second. When you say high thousands, do you mean 6 digits? 100,000 procedures, or
I would say less than 100,000 procedures. You know, one of the ways you could look at this is to say, okay, well, what's the prevalence and incidence of the disease out there? How many are there in the United States? And then how many of those folks have access to treatment? And just remember, not all patients with keratoconus obviously are candidates for cross-linking. The indication for the treatment is progressive keratoconus and post-refractive surgical ectasia. So you have to document the progression first of the disease, and also in most cases, and then also diagnose some sort of post-refractive surgical ectasia. And that's how the on-label procedure is right now. But different surgeons are doing it using different criteria. We have all the time. I think it happens a lot. I would love for Clark to jump in because Clark was actually really, well, both of us were around in the beginning of cross-linking, me with one device and Clark with another. The one that Clark used is the one that Clark worked with is the one that's FDA approved right now. And he'll probably have stronger data from those early numbers. I know we were in the thousands when we were doing ours back in 2010 through 2012, and like 3,000 to 5,000 in that ballpark.
Yeah, I don't really have I don't know that we've done a U.S. database in terms of tracking the number of eyes that were treated. And the insurance coverage is a relatively recent development because of the new riboflavin supply code since 2019. So they're getting better reimbursement now ever since that there's a code. So even if you're going to look through insurance billing at some point for cross-linking, you're still tracking more solid data after 2019, and thereby you're still missing a lot of accumulated total numbers. So I don't really have a good answer for that.
okay? Actually, that's pretty good. Jason, do you have anything to add as we wrap this section up?
I was just thinking about the sheer number of people with keratoconus or some form of corneal ectasia in our country now, and I think it's probably a lot more than we might think off the top, because I think the incidence now, we're coming to the realization it's probably less than 1 in 1,000, probably more like 1 in a few hundred even. So if we have 300 million people in this country, we have 1 million people with keratoconus. That's a lot of people, and the number of diagnoses every year then has to be in the tens of thousands, which means again that the number of people who are candidates for some type of procedure like cross-linking to slow or stop the progression has got to be in the tens of thousands.
Yeah, like I think the Dutch guys said 1 in 375 or something like that.
That's correct.
But they
for prevalence.
Right, but they have a single payer system that they could track through 4.4 million charts, where we don't really have that system in place in US.
Right, and that was off of billing codes, if I remember correctly.
Yeah. Okay, that's great. Let's wrap this section up. That was good, guys. So, that Jason has been holding up his counter there. He's usually meaning that I'm being cheap with the rings. And he thinks that even though my function is the moderator, that he should keep score also. Yeah, and so Jason, I ignored every one of your little things like this.
I understand.
Okay, okay,
I just,
great.
you know, I have to remind you, Craig, to not be chintzy with your bells. That's all.
Chintzy with my bells. You got
Yeah.
it. Okay, thank you.
And Jason promised me that he was going to give me his golden buzzer during this
Yeah.
episode. He's going to be the winner.
Yeah, exactly. Okay, Jason, 2 points.
I believe I had 2 before we even started that round.
Yeah,
so that's
but
pretty
once
bad.
you did this, I removed them.
Oh, I got you. Okay.
Okay, Andy is leading with 4. I am being chintzy because Clark's right behind him with 3 today.
See?
I will try to change that, but let's see if we can actually come up with some decent answers. Let me ask you
there
this.
goes the brown nosing for me, man.
Clark will beat me in the long run. I'm not worried. Don't worry.
Yeah, well, you know that you always have a 50% chance of winning on this show, even though there's
That's
3 of
right.
you guys.
That's true.
Yeah,
Craig will make sure I don't get
The
it.
best glasses on the show today.
Yeah.
exactly. Hey, so I have a question. You know, I was looking at the American Academy of Ophthalmology website recently, and it was listing the alternatives for the correction of keratoconus. And I think this would be on their patient site, right? And after they listed, you know, rigid contact lenses, they actually said hard contact lenses was what they said. The next thing that they said was an option was Intex. Is that a surprise to you?
Why, that it's not the head of contacts?
No, it's not a surprise to me. I know that. Oh, I'm sorry, Dave. May I interrupt? Is that what you want me to
Oh,
do?
No,
yeah.
no.
I don't get to go first anymore. You're right.
Jason got a point there for being funny.
I mean, if the point is if the question is why is Intex still in the conversation, which I think is Craig's question.
That is correct, Clark.
Right, and if you actually, so there are a couple of things. Number one, if you look at like globally in terms of usage of some sort of intrastromal ring segment, Intex is only one of them. There are many different designs. Overseas studies, even studies where they separate treatment, looking at cross-linking Intex and then say topo-guided PRK and separated them by stage, it actually has a lot of data showing that some sort of intrastromal ring segment gives the most amount of refractive changes to a keratoconus cornea after the cornea has been stabilized. So refractive benefit is there. The only thing is we're more limited in terms of our device option in the US. That's number one. Number two, a lot of people, I think, you know, again, going back to the management style, classically, we tell patients you only have 2. You have contact lenses, you have corneal transplant. That's it. You choose what you want, and most people, you know, choose one way or the other. I think we get into that mindset that if we could not find a treatment to replace the need for corneal transplant, then it's not worth doing. And therefore, something like Intex gets a lot of bad reputation because it is not supposed to replace corneal transplant. It's supposed to give you a way to possibly defer the need for corneal transplant, such as maybe giving chance of, you know, refresh the corneal contour and give you another chance to fit different type of contact lens.
May I interrupt?
You bet.
Just to not to stop Clark from talking, but I think it's important to point out that the goal is not to prevent the corneal transplant from a disease progression perspective, but from a refractive perspective. Is that correct?
Yes.
That's to say that Intex will not slow down the progression of the disease, and that's very important for everybody to discuss with their patients ahead of time.
That's not the design purpose, but I think a lot of clinicians mistaken Intex for if it's not going to slow down disease, number one. If it's not going, number two, if it's not going to replace the need for maybe an eventual corneal transplant, why do it? And I think that's the mistake, that's the confusion that people have. I have plenty of Intex patients who gets another, almost like they get a new release in life where they can get into a different type of contact lenses or get a little bit better usage out of their glasses at night for a couple hours. And they're very, very happy. So I think it's about our education and our understanding.
Yeah. I would also add, may I interrupt now or may I talk?
Come on.
Awesome. I would also add, Clark and I really have the pleasure of working with Bill Tullo, who's really expert upon expert in corneal tomography and topography analysis. And he says all the time, and he's been saying it since day one, is that intacts are not going to make your contact lens fit easier. It's going to make your end result vision hopefully better. And I think that's really important, because once these intacts go into the cornea, it's not to say that your complex contact lens fit is going to be a simpler process. In fact, it could be a more challenging process. And I think that's a consideration to take in ahead of time. I will also add, one of the things that I've always been confused with about intacts, it just never made sense to me, is that when you have a patient with keratoconus, you already technically have a patient with a disease of weakened collagen, where the cornea is obviously starting to bulge. And now you're creating a tunnel within that weakened collagen and implanting a polymethyl methacrylate semicircle ring inside of it. My question, and I can't prove it anyway, because I don't think we have enough diagnostic technology to do so, but if you already take a weakened cornea and you put a tunnel inside of it, you incise into it, could it destabilize the cornea even more, and could you have a weaker cornea afterwards? And that was always my big concern and worry. So that's just a consideration that I would put on the table.
Yeah, and
Excellent.
may I interrupt with actually a relevant point maybe? I think to that point, I've also felt not only the tunnel, Andy, but also that your intact is pulling and stretching the cornea to tighten it, if you will. That's the whole idea, is you're going to stretch that tissue, if you will. And if the fibers are already slipping, does pulling it make them slip further? And so I think, intacts in probably done in the right way is coupled with cross-linking or something to strengthen the cornea when you do it. But the one thing I think that gave intacts such a bad rap early on was they were fairly done indiscriminately when they first were approved for use with keratoconus. And there wasn't a rhyme or reason as to why you would use it on one patient or why you wouldn't use it on another for a lot of doctors. And I think there's a very clear picture of the patient who will benefit from intacts and those who really won't. I've seen lots of patients who were disappointed in their intacts outcomes. These were all patients that already had basically 20/20 vision with their rigid contacts. They had a high prescription, and intacts wasn't going to get them out of their prescription. And so they had this done, and they're still in GP lenses, and they still have the same vision, and they don't see any benefit. I think the patient who intacts benefits most is just like Andy and Clark have said, the ones who have where it remodels the cornea, where it can reduce some of the aberrations that are part of keratoconus by reshaping the posterior float a little bit, and we can get a better refractive outcome. Those low to moderate myopes can get a refractive benefit from it too, so they don't need corrective lenses as desperately. And I think, again, if you're selective about who goes into intacts, I think they can be very effective still.
Okay, fellas, I have to tell you, that conversation was a heck of a lot more interesting than I expected that stupid question was going to be when I first said it. You delivered some really fascinating points, and I think extremely educational. Clark, I'd like to follow up on that with you for just a second. You mentioned a number of the other types of ring segments available elsewhere. Do you foresee any of those entering the U.S. market?
I have seen a lot of patients coming from different outside the U.S. to come see me for contact lens fitting. So I have seen many different type of devices implanted. I don't foresee them coming into U.S. No.
And that's purely because of the size of the market and the cost to get into the market. Would it be that?
Exactly. So if you look at the two separate things, if you look at and this may be a conversation for another day, but we all know recently that corneal inlay, they used to be more than one design, and they sort of got thinner because of some of the recall that had happened and funding that runs out. So when one device gets a little bit of bad reputation because of misunderstanding, there's not as much interest in that in that device. And it's the same thing with Intex. Once you sort of get that misunderstanding, a lot of surgeons that I talk to who are still implanting these devices love them, but enough of our optometric colleagues don't like to refer for them. And so there's not really enough interest there for me to see other device companies trying to spend the funding in getting FDA approval. So I don't foresee anything else entering the US market.
Okay, that is great. Guys, any more comments about this Intech discussion at all?
I do have one more thing. So I want to go back to what Jason said. Remember I talked about the different type of limitations to Intex and misunderstanding. The third one is about contact lens fitting being made more difficult after Intex. Granted, I think it may be true if you're talking about corneal GP. I don't think it's true in any other lens devices. And therefore, I think in the diversity of lens designs we have, I'm not quite sure why we keep going back to a lens design that is challenged after Intex when we have plenty of other lens designs that are available. And I think that is another reason for why we tend not to want to refer patients, or at least want to, even if the identification and selection process could be correct, could improve, we're still not going to get enough patients to benefit from this procedure, because ultimately we have enough doctors who think that contact lens fitting is made difficult, even though that's not true for example, scleral lenses or other type of lens designs. So I think maybe we could do better at that.
Okay, Clark, that was excellent. Okay, so round 2. Jason, 5.
Not bad. I'll take it.
Andy, 5. Weak
Ooh.
segment, buddy. Really weak.
I let him catch up.
No pun intended.
That's nice of you. That is great.
No pun intended about Intex, right?
Yeah.
Right.
And Clark is at 7.
Uh-huh.
And I have to open up the floodgates a little bit more, but I like a tight race. I have to keep tight control so that Jason is at least within a standard deviation of a chance of winning.
I so appreciate that, Craig.
You're welcome. You're welcome. Okay, so what I'd like to ask you guys is, typically right now we want to talk for just a second. Our sponsor is OCULUS, and they make instrumentation that we look at as being the Cadillac in many cases of instruments available. Andy, can you talk a little bit about your experience of working with OCULUS and their instrumentation?
Yeah, sure. I'd actually love to. So I unboxed my first Pentacam in 2005. And I'll never forget it, because when I say I unboxed it, it came over from Germany in a box, and we had a technician come over, take it out, and plug in the device and said, okay, here we go. You're ready to rock and roll. And which was atypical for anything else that we've ever unboxed before. And to be quite honest with you, I had to learn how great this device actually was. To me, and let me just say that I don't work for Oculus. I don't take payments from Oculus. This is my opinion. It is absolutely, at the time I was working with TLC in the Rockville office, we're the busiest office in the country, and it absolutely changed the game. And we went, that's when keratoconus went from a front surface disease to a back surface disease of the cornea for me, because I learned the actual shape and the elevation of the cornea where I really didn't even have a concept of what it was before. We were the first, I think we were the first center of TLC in the United States to get a Pentacam, and it was really on us to learn it well. At the time, Mike Bellin was still at George Washington University, so he was in town with me at DC, and I got to pick his brain. Mike Bellin, being half of the Bellin Ambrosio display group that developed all that analysis material and software within the Pentacam. And, I got to learn it real time with the expert who is really developing all the software for these, for the analysis for keratoconus with the Pentacam. To answer your question in a short statement, it is, to me, and this is my personal opinion, unbiased, it is the most advanced corneal mapping device commercially available that we have on the market that gives us the most, the broadest understanding of the elevation and shape of the cornea in a rapid testing sequence that could be most effective for the diagnosis of disease and also the treatment and management of the disease.
Okay, that's great. And I think we found our new moderator.
Can you really be the judge of your own personal opinion, not being biased? Because there's a lot of things I like to say about myself too.
Clark, do you have anything to add there?
I do. So albeit that Andy has much unboxed his Pentacam way before I did. I do want to say another thing about Pentacam, and that is we've stressed in our previous segments about early diagnosis due to the availability of cross-linking since 2016 in terms of FDA approval. I do want to point out for me though, Pentacam is one instrument that made that early diagnosis a possibility clinically for me. Not that we couldn't diagnose keratoconus before with our other instruments and combination of different instruments. We could pick up a retinoscope and look at Caesar reflex. We could do placido ring disc video keratoscopy, whatever that you had before. It really for me is a game changer and continues to be the leader in that field so that I can look at both anterior and posterior elevation profile in detecting keratoconus as early as I possibly can. And that really, I have not found other instruments that really allow me to do that in my clinic. But it's one thing that I just feel like I really do not, for the time being, I cannot live without for my patient care.
Okay, that really is terrific. Yes, Andy.
And that is also not biased.
Yeah. So just to add, and Clark and I have been lecturing on this and teaching this, more importantly, to students and other eye care professionals for years. I've been out of school long enough where I was in school during the CLEC study, and Heidi Wagner at Nova Southeastern was my contact lens chief. And so she taught us everything about topography and anterior segment evaluation, anterior surface evaluation. And it really, learning all that stuff and learning how GPs work with keratoconus and the whole, if you remember the Fidakal fitting guidelines, it changed, the Pentacam changed everything. It changed our whole concept of understanding of it. Not to say that any of that information was bad. It was amazing. And I for the record, I want to say Heidi was an unbelievable, and the whole staff there was an unbelievable contact lens team. But it just changed. We were in school at a certain time. I don't know when, Jason, when you graduated from optometry school. I graduated in '99. But, with the advent of the Pentacam and with understanding posterior elevation of the cornea, the entire everything about the understanding of keratoconus changed within my career of optometry. And that's one of the things I find so fascinating about it. The key linchpin to that whole dynamic shift in the understanding of how the cornea works with this disease is the Pentacam. And in no uncertain terms, like Clark said, it's my favorite device. I couldn't go to work without it to see these patients now.
Hey,
Okay.
Andy,
Yeah.
I just talked to Heidi. She sends a ding for you.
Thank you. Awesome.
That was pretty cool, guys. I mean, of course, we know these are unrehearsed and not even brought up normally until the moment I ask you guys your opinion. And those are really unbelievable testimonials on how well the instrumentation works. So to close up on things today, we'd like to just have a little crystal ball and look in the future. And, Jason, I'll start with you. Where do you think we will be in 5 years from now in the management of keratoconus?
Well, I'd like to think that we're going to see continued improvements in how we deliver cross-linking in a way that puts the cornea at less risk, even though the risk's small now. I mean, just, increasingly doing it in the least invasive way possible. I think we're going to be correcting higher order aberrations more routinely in our contacts. I think that's going to be there in 5 years. So we'll be giving our cone patients better vision. And, as far as the concept of like a topo-guided PRK, ablation to try to re-smooth the cornea, I think that's a possibility. I haven't looked at enough maps to feel 100% confident that we're not altering the posterior float on some of these, but it would be great if the data on that was such that we could prove and know for certain that doing those types of ablations wouldn't cause progression. I think we'd see more of that too.
Okay, that's great. Andy?
Sure. It's a great question, and I want to make sure I don't mince my words when I say this. Keratoconus is a disease of a weakened cornea. It's a weakened collagen disease. And with devices like the Penacam and soon to be others, I'm sure there's going to be more advances in the diagnostic field in the future. There always is in medicine. We can detect this disease earlier and earlier with every iteration of machinery that comes out. We also know that the earlier we diagnose, the better it is for the patient. And with cross-linking, we know we can halt this disease in place. Keratoconus, and like I said, I don't want to mince my words, keratoconus is an optometric disease. And what I mean by that is that there are more optometrists out there. We are the front lines of primary eye care. We're seeing these families and these kids at a very early age. We can identify this disease as early as possible and treat it as early as possible. And quite frankly, with cross-linking now, the only incisional surgery required for this disease of keratoconus is a corneal transplant or a partial thickness corneal transplant. If with corneal cross-linking, we can eliminate that from happening, the only time the patient would have to leave to go to the ophthalmologist is if our cross-linking procedure didn't work and progressed to the point where they needed some sort of incisional procedure, whether it's a femtosecond or a blade to remove the cornea. That being said, I think this disease in the future, you're going to see it identified, diagnosed, treated by an optometrist with cross-linking in the doctor of optometry's practice, and then fit into advanced medical contact lenses afterwards. Those patients are going to stay in our offices. For the most part, they're not going to leave. I believe that optometrists will, in 50 states, be able to provide cross-linking in the future. If you look at the technology right now by Farhad Hafezi over in Europe, he's developed a slit lamp mounted cross-linking device. So these treatments can be done directly at the slit lamp in a very short time frame. I believe this is, like I said, keratoconus is a optometric disease, and it should stay in our practices.
What do you think about that, Andy? Do you think it's at the primary care optometric level, or will be at the specialty optometric level?
So
Where do you see that fitting in?
I'm sorry to interrupt.
You may.
Oh, thank you. So I think it's going to be, just like we have right now, certain optometrists choose to do certain procedures, and they stick with what they're good at. Shame on you if you come to Clark or my offices with a big fat retinal hole or detachment. We're
Speak for yourself. I'm pretty good at retina.
Okay, well,
I'm just joking.
Canadian retina, not American retina. And I joke when I say that, but I think it's going to be by choice. I think certain doctors of optometry are going to have subspecialties within their practice that they're going to feel comfortable with. And I think every doctor, whether they're an optometrist or not, should stay in their wheelhouse with what they have expertise in and what they feel comfortable with treating their patients. If they don't, the option to refer is always there.
Excellent. Clark?
Yeah, I take a slightly different angle than both of them, as always. I think, so, before I give you my conclusion, we did a study reviewing 329 chart review for 329 eyes when I was doing my clinical fellowship. And we looked at patients who coming in wanting surgical intervention because of the fact that they've given up on contact lenses. And then so we broke them down in groups of people who were doing relatively okay, not great with their contact lenses, asking them if they would consider being refit by me first prior to, if they failed, then maybe go on to having either cross-linking intacs or topo-guided PRK or kind of other potential surgery. So when we looked at the two subgroups, those who agreed to be refit by me versus those who decided that they don't want to, they want to get surgery before seeing how well they do. Maybe if they don't need contact lenses, and if they do, they're not upset, they'll come back to me. So if you look at the success rate of their prior to being refit by me and prior to surgery, the group that went with surgery had about 40% or less success rate prior, and then the group that agreed to be refit by me had about 60-70% contact lens tolerance. They both went to a nearly 100% after either refit by me or after surgery and then come back to me. So of course you can draw a conclusion that I'm just such a good contact lens fitter, almost as good as Jason, Craig, and Andy. But I take a different route. I take the route that contact lens has synergistic effect with different type of surgeries on the cornea. So I think in the future, what you're going to see with all the advancement we have in contact lenses, and they are excellent, and thanks to people like Jason who can keep giving us better tools to use. But patients are always...
Too much pandering. Keep going.
Patients are always going to want to try to do the easiest route. So that means they're going to ask for combination surgery. They're going to have cross-linking and topo-guided PRK. They're going to have cross-linking intacs, topo-guided PRK. They may even have intacs. They may have even asked for cross-linking. And there's a new procedure called CAIRS, which is an allograft that is transplanted tissue to be made into an intact shape and then implant into the cornea so that you don't have to worry about synthetic material in the cornea. So I think there's a lot of refractive surgical options for keratoconus patients as long as it's combined with cross-linking, and we could fit them in contact lenses in the future because hopefully they're going to be even easier patients to fit after all those surgeries. So I think that is the future of keratoconus management.
Thank you, Clark. Excellent.
I do want to compliment Clark here for something that he and Barry Iden as well we've always discussed this, and they've always harped on this, is that, generationally right now, we're moving to different types of contact lenses, and not to take anything away from scleral contact lenses right now. But what Clark has always told me in his clinic, certain corneas do well with different contact lenses. And I think it's really important not to forget the entire armamentarium of specialty contact lenses that we have. Clark, I've seen it, and I've seen his cases on paper and stuff that we presented where, everybody might be going to a scleral lens on a first try for a certain type of patient, where Clark probably thinks that he can probably fit that patient better with better visual outcome with a gas permeable lens. There are certain lenses that still work great, even though they're not new, hot, and sexy right now. And I think it's important for each patient to be treated as an individual. And Clark is obviously a tremendous advocate for that individualized contact lens fitting.
Excellent. Jason?
Oh, I got nothing to add.
Okay. He gets a point.
See, that's my best bet right there.
He gets a point for really stating a fact we agree with. Okay, guys, that was fantastic. Let me just say this, that I thought that for sure Clark was winning with the pandering, because he did a really, really good job with that.
It usually happens.
But then Andy recovered pretty quickly there at the end.
Can I throw out a few more compliments?
Yeah, I know. It's too late. It's too late. That it was fantastic. So I know you can read this. What it says is...
Hold that up one more time. I just want to take a screenshot so I can email it to Clark every day for the next month.
Okay, I will. Right here. See this?
Hold it higher. There you go.
Andy wins by 1.
Oh, wow.
Wait, how do you do the?
There you go.
Really?
I think you should take a point away for him just doing that right now.
Was that supposed to be a Heisman look?
No, I think that was the guy, the runner from Jamaica. What's his name?
A Bolt.
Oh, Usain Bolt. Yeah.
Give him a point.
Yeah.
Guys, in all seriousness, that as we bring this to a close, this is really a fantastic time here today. That I think more than anything is the educational value of what you've been able to deliver for us today. Understanding a little bit more of where we're at with keratoconus, this discussion of cross-linking and looking into the future. I think really it's a very, very interesting episode that we had, and I really thank you both for your time. Jason, do you have any comments to close?
No, I enjoyed it, and again, it's always great to have guests here who have such a deep knowledge of a subject and can share it like this. So I appreciate both of you guys being here today and just getting to learn from you.
Excellent.
Same
Totally
here.
agree.
Thank you.
Clark,
Thanks so
thank you. Andy, thank you. Jason, of course, as always, thank you, my friend. And thank you all for either watching or listening. May I Interrupt episodes are available on YouTube. And also the podcasts are available on Apple Podcasts or wherever else you want to download them from. Thank you very much for listening and watching.